My name is Sarah St. Hamilton. I'm the Director of Social Support Services, and I started with CARE, I think, in 2022. So I started at the very beginning. I'm kind of the founding Director of Social Support Services. I have a background in public health and social work. I'm also a lifespan developmental psychologist. That's what my PhD is in. I spent a number of years after graduate school just mainly focused on teaching here in the Institute of Gerontology. And I really found that I missed the client interaction, kind of the social work side of things. I jumped at the opportunity to lead the development of the social support programming and oversee social work interns and provide case management services and interact with patients, all of that. That was all very intriguing and exciting for me because I think that was the piece that I missed the most about being a social worker. When I was a social worker, I did lots of home visits and spent lots of my time educating the people that I worked with on best practices and things like that that I found in the research. And I think that was one of the pieces that I really missed the most about teaching, was that kind of one-on-one working with people in the community. It's definitely very dynamic. There's a good bit of routine to it, but of course every family that comes in is different. Every person that comes in is different. You know, we have folks moving through the process of all of our services. We offer both diagnostic services and just social support consultations. Even if folks don't get their diagnosis with us and they already have it from a different provider, we can still provide education and support and referrals to resources, things like that. For the folks who come to us for diagnosis, typically the process is we usually get a referral from a provider that they're working with, whether that's their primary care provider, sometimes even a neurologist. They'll send their patients to us for the neuropsych evaluations, that big workup. One of my social work interns will call the patient or the care partner, whoever's initiating this, and complete a pretty lengthy screening, get a lot of background information. And then they present everything that they learn to the clinicians at our weekly rounds meeting. And then the clinicians determine from there what the best next step is, whether that's an appointment with our geriatrician or an appointment with just straight to neuropsych testing. Or sometimes it's that really it would be best for the patient to see a different type of specialist first. And so they're able to make those recommendations to ensure that the patient is receiving the care that is most appropriate and most needed at the time. So there's a lot of talking with folks on the phone, completing these screenings, scheduling appointments, and then when we have folks coming into the clinic for their appointments, myself and one of my students usually goes into the medical appointment that they have with Dr. Scott, and we complete a social support consult that's kind of just brief in the beginning, but we just want to make sure that from the start we are checking in with folks and making sure that if there are any sort of social needs, resource needs, anything like that, educational needs, that we're able to provide the information and referrals that they need for that. And then we also do a caregiver support group. So twice a month, right now it's on Thursdays, but it changes depending on the semester and the schedule. But twice a month we usually have a caregiver support group that I facilitate And then at the same time, we have a music therapy group for folks with a dementia diagnosis, which is often very helpful for the caregivers because it eliminates barriers to their being able to attend support group if they also have something that they can bring the person that they care for to that is fun and engaging and good for them as well. My understanding of how Jenny runs music therapy, we are a training clinic, and so she always has music therapist students who are actually running the session. She's there, of course, helping too and overseeing, but Jenny was saying the other day that they're able to get exposure to a wide variety of, different types of songs that are from very different eras than they're used to. And it's really good for them to have to learn these new songs that they wind up having to play for the folks who are in the group. But the goal of the group is not so much for the participants to learn a new instrument or hone their musical skills. It is music therapy, and so it's better thought of as using music as a therapeutic tool, a way to connect with folks with dementia, a way for folks with dementia to practice using different skills and also practice retrieving older memories. So typically there will be a theme for the day of all the music will be on a certain theme, and then they'll have questions that will go along with the theme. And so if one of the songs was, I was working on the railroad or something that is from that person's youth, and they're definitely gonna know, they're gonna know that song. They would ask questions that were related to that theme. So it might be, have you ever been on a train? Did you ever take a trip on a train anywhere? And they're always questions that set the person up for success. They're not questions that have a right or wrong answer, which is really important because it's not like a test. It's just trying to engage with the person and in a way that allows them to answer with whatever comes to mind and have that be a good answer. So most of the time folks do remember things, from earlier on in their lives. It's the more recent memories that are harder to access. And so if you ask them things, from their 20s or their 30s, they probably will remember those kinds of things. So. I think there's so much involved in dementia care, and when somebody gets a dementia diagnosis for themselves or their family member, it's pretty devastating, and there are so many kind of surrounding pieces to that diagnosis and kind of ripple effects to that diagnosis that often don't get, people don't get advice on, or they don't get education on at a doctor's appointment where they get that diagnosis. So oftentimes the next steps, the educational piece, the support is not provided because it's not within the scope of that specialist's skill set. It's not within their role really, unless they have a social worker or somebody on staff who can provide that. And so I just feel really lucky and a lot of fulfillment in being able to be there for folks when they're in that very vulnerable place. They've just gotten a diagnosis, they don't know what's going on, they don't know what to do next, and to be able to provide some next steps and some education, some reassurance, it's really rewarding for me to feel like I can actually make a difference for this person who is going through a really difficult time with a lot of unknowns.